Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician and senior physician advisor here at the AMA. As physicians, many of us chose to practice medicine because of the relationships we develop and the sacred trust between patients and their doctors. People will tell their doctor things they won't tell anyone else, and we always want to do what's right for our patients, depending on their needs and honoring their preferences as much as possible. For patients with serious illnesses, we know they're facing many different decisions that can be frightening and confusing. Having those difficult conversations about a patient's wants, needs, and priorities can sometimes take a back seat when major medical decisions are hanging in the balance. It also wears on us as physicians. It makes the challenge of caring for patients that much more heavy at times. And so we may have a tendency to avoid these difficult conversations until they fall right in our lap. Recently, I needed to call a long-standing patient of mine and her husband into the office to give them some hard news about her lab results. And I can tell you, after more than 20 years in practice, having to do this hasn't really gotten any easier. Ariadne Labs' Serious Illness Care Program is working to redesign care so that knowing and honoring patients' priorities becomes the new norm. To share strategies to integrate timely, person-centered serious illness conversations and care planning into routine clinical practice, we're joined by Dr. Erik Fromme and Dr. Namita Seth Mohta. Welcome, and thanks for joining us today, Dr. Fromme and Dr. Mohta.
Thanks, Kevin. It's wonderful for us to be here.
Thank you.
So before we get into our conversation about the Serious Illness Care Program at Ariadne Labs, could both of you tell our listeners a little bit more about yourselves, your background, and your current positions and work? Maybe we'll start with you, Dr. Mohta.
Absolutely. Thanks again for having us here today. I am a clinician. I see patients as a hospitalist at the Brigham and Women's Hospital. And although at this point that is a small piece of my portfolio, it is the core of what I do and what drives me every day. When I am not seeing patients, I serve as the executive editor at NEJM Catalyst, which is a publication by the New England Journal of Medicine that's focused on practical innovations in healthcare delivery. I also spend time here at Ariadne Labs with the Serious Illness Care Program team focused on building and scaling our care delivery model to improve outcomes for patients with serious illness. My background is in and has been on care delivery transformation and really focused on how we make the systems of care better for our patients. And that has had a long meandering career through academic medical centers, health tech startups, nonprofits that we'll talk about another time. I'll hand it over to Erik.
Hi, everybody. I'm Erik Fromme. I'm a palliative care physician. I see patients at Dana-Farber Cancer Institute here in Boston. The rest of my time is spent as a senior scientist and faculty with the Serious Illness Care Program here at Ariadne Labs. And I guess my work, well, over the last 7 years, it's been very devoted to the mission of the Serious Illness Care Program. I would say broadly, my interest is in trying to help clinicians and patients connect with each other and align around what is most important.
Well, great. Thank you both. And again, welcome to the podcast. Could you tell us a little bit more about the Serious Illness Program at Ariadne Labs and maybe some background about its mission and how it got started?
Yeah, I'd love to. Ariadne, the name for the lab, which was founded by Atul Gawande, comes from the Greek myth, Theseus and the Minotaur. The myth is that Theseus had to go into the labyrinth and face the Minotaur, but nobody had ever been able to find their way out again. And so Ariadne gave Theseus a thread, and he unstrung the thread as he went in. And then after he battled the Minotaur, he just followed the thread right back out. And so Atul's inspiration from this thread was that it's a simple solution to what is a very complex problem. And so our lab is inspired to try to identify solutions within healthcare, even within the complexity, that are simple and can be implemented and spread. And so for the Serious Illness Care Program, the thread, it comes in the form of the Serious Illness Conversation Guide. There's a backstory with Atul Gawande there as well. In researching his book, Being Mortal, he was going around to different palliative care clinicians and trying to find out what it was that they were doing that was different from what he was doing as a surgeon. And he couldn't really understand what it was until he met Susan Block, who's a legendary palliative care physician and mentor, who told him, Atul, instead of talking to your patients about the procedure that you may or may not do and the risks and benefits and whatnot, why don't you ask them these questions instead? Ask them what they understand about their illness and their prognosis and how much they want to know about that. Ask them what their most important goals are. Ask them what their biggest fears or worries are. And then ask them what are the things that they're willing to trade off or not trade off for the possibility of getting more time. And Atul, being who he is, he wrote those questions down on his little 3x5 card and left and called Susan back a month later and said, I've been asking my patients this in clinic and it's totally transformed the nature of our interactions. And by the way, it's brought me back to why I wanted to be a doctor in the first place. With that sort of auspicious beginning, our program's really dedicated itself to trying to figure out how to make these important, crucial conversations, as you called them, just part of the standard of care for any patient with a serious illness.
One of the things about Ariadne Labs is that we are a learning organization and we are about real world learning. So our goal is to always be out in the real world, implementing the program, learning what's working, learning what's not, and then bringing it back to the lab so we can incorporate that into our research projects and our care delivery model. And I would add that with that foundation, what we do today is very much build on those guiding principles to organize around building tools, ideas, and community around this notion that we want every patient to be known and cared for on their own terms. So whether it's a toolkit of how to support not only individual clinicians in terms of having these conversations, but also support at the team and health system level, our research agenda and the new ideas that we are learning around. And then lastly, building community internationally around people who care and are vested in this types of patient-centered care model is what we do today.
All right, fantastic. And Dr. Fromme, I heard you say that thread for Ariadne is the Serious Illness Conversation Guide. Is that something that's a formal structure outline for how to engage patients in these types of discussions?
Absolutely, that's exactly what it is. Those 4 questions that Atul wrote down on his 3x5 card then became sort of the nucleus for the Serious Illness Conversation Guide, which is basically it's a 1-page structured list of questions that you can use to engage a patient and talk to them about their prognosis and their values and their goals and what's important to them. I'll say, in palliative care, it's a little anathema to give someone like a script, right? Like we are taught to sort of follow the patient's lead and sort of respond and react to the conversation that they want to have. But that is exactly, I think, what was confusing Dr. Gawande. It did not make sense to him. At this point, I don't think I could be more trained or more experienced in having these conversations. Honestly, I do better when I follow the questions on the guide, because all of that thinking that I try to do otherwise to personalize the conversation doesn't always work. And it's not actually about what I'm saying. It's actually about giving the patient the opportunity to talk and giving me the opportunity to listen. So even with all the training I've had, I actually use the script. Sometimes I'll hold it in front of myself and the patient can see what I'm doing. Over time, I found that to be, especially when I'm nervous, a huge support.
Yes, and I think that's a doctor thing, especially if we get nervous or anxious, we tend to talk more, and sometimes we we talk more than we should, certainly more than necessary, and we think we're giving information, but it's okay to just stop, pause, let what you've already said sort of hang in the air or rest on the receiver. I hadn't thought of this before we came onto the podcast today, but 2 years ago this week, my mother-in-law passed away very suddenly, unexpectedly. She had a heart attack and never made it out of the cath lab. And the cardiologist who was doing her cath came out to tell us that she had died, and he delivered that news, but then proceeded to talk about the technical aspects and things that went wrong and things that we weren't ready to hear because we were still in shock about the first message. He thought he was helping, but it wasn't helping.
Thank you for sharing that. I encourage all of our listeners to take a look at the guide. When I say it's structured, it is very structured to the point that my favorite part about the guide is a line that says, pause here. It literally tells me to stop talking. And that creation of space is what I need in the moment to be with my patient. And more importantly, for the patient to sit with the conversation that we are having. That word pause also makes me talk slowly. Given that I'm talking more slowly now than when I first started the conversation is telling for that. So I know that we all bristle at standardized anything, but in this case, that structure really has impact and works. And I'll let Erik talk about this, but there is data. Over the last 10 years, there's been one signature trial at the Dana-Farber Cancer Center, and then probably dozens of other ones that demonstrate the impact of such an approach. But I'll hand it over to Erik.
I guess what I would say is, in general, there are benefits to a structured approach. It's not all benefit. There's some downside as well. One concern when we first started this, particularly in the cancer center, was, will this take away patients' hope? Our program founder, Dr. Block, observed that she thought it would have a very different impact because she recognized that, particularly in a cancer center, patients often know that they have a prognosis and they suspect that it might not be good, but it's actually uncommon for them to get to have a conversation about it. And so her observation was that the clinicians knew that too, and that they were anxious about it as well. And so the premise actually for the study that we did was if we could have these conversations earlier, like not precipitated by a crisis or a need to transition to comfort measures or to enroll in hospice, if we could engage the patients while they're still going through their cancer treatment in a conversation, that would help with this anxiety that they were experiencing. And that's actually what we found. Far from losing hope, what we heard from them was that their anxiety was better, that they were less depressed. And the impact on their anxiety actually persisted over 4 months. It was a durable effect. And so I think, it's a simple thing, but I think it can be very powerful. And, I think for the clinicians who did the conversations as well, I think a lot of them found the conversations difficult, as you described. And I think some of the conversations are difficult, but it did seem to be valuable to them to have the guide to fall back on. And they were able to cover more ground in a shorter period of time using the structure than I think if they just tried to wing it.
Well, and like anything else, they'll say that the way to get good at it is to do it over and over again, to practice it. But the way you practice it can be much more effective if you have some sort of structure for your practice. And so thinking about what are the best questions to ask, in what order, allowing time for thought, reflection, response. It seems like having a structure to practice would be very beneficial. So thinking about barriers to physicians really being able to engage in these type of meaningful conversations that have a good outcome as best they can. What are barriers to that, and what can practices or health systems do to help better equip and support physicians to engage in these conversations with their patients?
We all know and want to have these conversations with our patients. Structure sounds great. And what I am thinking, if I am a busy clinician, which is I don't have the time, structure or no structure, I don't have time to pause because I got a lot to do in my, X minute wellness visit or my X minute follow up. So the conversation feels like it's half an hour, but it's really 9 to 14 minutes is the range that it can take. Of course, it can take longer, but it does not take as long as we think it will take. And again, because of the way the conversation is structured, feels much more meaningful, which then I think is what results in both the positive experiences of both the clinician and the patient and or their loved ones. So that's one point I'll make. And the second point I'll make or emphasize, Eric, that you made, which is that we have learned over time the essential pieces around the training component of this. So what once used to be a multi-day training, then became a shorter training, then became now we have a combination of synchronous and asynchronous training and have shrunk it down from 2 days to 3 hours. And we haven't shrunk it down just to shrink it down. We've shrunk it down with intention and with learning and with engaging the expertise of our lab. That includes people who are specialists in adult education and people who are experts at human-centered design, implementation scientists and researchers. So now what we have is something, the takeaway here for our frontline clinicians who are listening is that the conversation is accessible within our busy day and that the training is accessible within our busy day that will have long-term impacts. And so that's the front line. Taking a step back and thinking about what needs to happen at the health system level and addressing the barriers that's more macro and bigger than any of us frontline clinicians is really thinking about 3 different building blocks that the program has been organized around or has evolved towards over time. The first one is about leadership and engagement. We all know that unless you have engaged leadership, sustainable change will not happen. The second bucket is around practice change, and that's where some of these training programs come in, thinking about workflow, integrating with our electronic medical record, thinking about incentives. We are all incented to do a lot of things. We've got to close a lot of care gaps. And so we need to think about how do we restructure and align the incentives from the front line all the way to the boardroom around incenting these kinds of conversations that have positive outcomes at every dimension. And then the last one, which is incredibly important, is measurement and evaluation. Those are some of the things that we spend a lot of time and energy focusing on a macro level at the same time that we're focusing on supporting our frontline clinicians. And I use that term broadly. We're now actually more focused on thinking about things from an interprofessional level and thinking about how does an interprofessional team actually support this type of care.
Yeah, I think those comments that you made are really key because, as a primary care family physician, I'm thinking all the stuff that I already have to do with all my patients, and I'm thinking, okay, this is one more thing. It's a really important and valuable thing, but I need help prioritizing or deprioritizing and de-implementing some of the things that I've been doing historically that are no longer as important or as necessary as this may be, especially for the patient right in front of me. Is there anything that you've learned or observed about the effect on physician well-being and stress levels and burnout that comes from being better equipped to have these conversations with patients?
So, we kind of have encountered the issue of clinician well-being through our efforts to try to get this practice change to happen. And generally, clinicians believe that the conversations are important. They think it's part of good care of the patient. They like the training that they get. They say they feel prepared to have the conversations after the training. But then on the other side, it remains really challenging for all of the reasons that have been mentioned. We interviewed non-palliative care clinicians who were having the most serious illness conversations in their system. it was very interesting talking to them. Not surprisingly, they all were doing it because they all believed that it was really important and that they couldn't take good care of their seriously ill patients without it. But the other thing that they said is that in order to do this sustainably over time, they had to learn how to better manage the emotional content of the conversations. There can be, sadness or grief or disappointment. What was fascinating to me about the clinicians was that they had all figured out different ways of doing this. I would have thought that hearing about how they were doing it would sound very touchy-feely, but it didn't actually. It just sounded practical. It was also striking that they'd all found their own way to do this. Nobody described, having a mentor teach them or being taught how to do this. They'd all figured out how to do it on their own. And I realized as healthcare, it seems to become more and more difficult and more challenging to our well-being. I think one of the capacities that has not been fully developed in healthcare, I think we do great at developing our intellectual capacity. And I think the proceduralists do great at developing their physical capacities. But I think that we have a lot to learn from the psychologists and the chaplains and the social workers about how to develop some emotional capacity as well.
Is there anything that either of you have learned that can help, even in a short period of time, folks build some degree of emotional capacity?
We are a collective team of humans trying to make the world a better place and be in service of patients and those with illness. What I have optimism about is that there is now more than ever a sense of urgency and ownership at both the policy and the system macro levels to address a very key component of clinician well-being. And so for years it was, go do yoga and go do some mindfulness, but you know what? Still meet all your RVU targets. And now what I am optimistic about is that there is pressure coming from a lot of different arenas on the macro systems to ensure that there is accountability about that level, putting into place the structures, the incentives, the governance, the data, all the things we've talked about to ensure that it feels more like a supportive team effort rather than an individual pursuit of your own emotional capacity.
One of the clinicians had read this book called Against Empathy. It was basically distinguishing between empathy and compassion. And what he learned was that he could focus on the fact that he was doing something good for his patient, that he was acting with compassion, and he really didn't need to engage with the emotion. That he could have a boundary there and let them have their emotions, but he didn't need to feel their emotions in order to take good care of them, and that really made it work much better for him. So again, I think boundaries can be useful.
Yeah, creating and honoring boundaries is a great way to build some margin and capacity in your life. And we have AMA Steps Forward podcast about that, a webinar about it, and some other resources that I'd encourage folks to check out. All right, Dr. Erik Fromme and Dr. Namita Seth Mohta from Ariadne Labs Serious Illness Care Program have been our guests today. Thank you again for sharing your time and for your expertise in this important work that you and your teams are doing. And we invite listeners to check out the resources that are mentioned in today's episode in the episode description. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.